From the JAMA Network, this is JAMA Ophthalmology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Ophthalmology.
Hello, and welcome to our listeners around the world. You're listening to JAMA Ophthalmology Author Interviews. Thank you so much for joining us. I'm Neil Bressler, Editor-in-Chief of JAMA Ophthalmology. And today, we're going to look at the visual acuity outcomes using different Aflibercept doses for polypoidal choroidal vasculopathy, also known as PCV, in a post-hoc analysis of the PULSAR randomized clinical trial. And joining me is the corresponding author of that report, Professor Tien Wong. Professor Wong is a professor and dean at Tsinghua Medicine at Tsinghua University in Beijing, China. And Tien is on our editorial board for JAMA Ophthalmology. Tien, thank you so much for joining us.
Thank you very much, Neil. It's a pleasure to be here.
Maybe you could just start for our audience, not all of them, maybe know what polypoidal choroidal vasculopathy is, even though it's endemic in many parts of Asia, and it's also common in people of European, North American descent. Give us a little, maybe 1-minute background on what's polypoidal choroidal vasculopathy and maybe how it differs from typical neovascular macular degeneration.
Yeah, thank you very much. Polypoidal choroidal vasculopathy, or PCV for short, is thought to be a variant of type 1 CNV, or type 1 neovascularization, or your typical AMD. And PCV was thought to be more common in Asian populations, comprising possibly between 30 to 50% of Asian patients with typical neovascular AMD. However, it's been shown in many different studies now that it is reasonably common as well as a subgroup of neovascular AMD, even in Europeans and in Caucasian white patients. So PCV is different from typical neovascular AMD in its presentation. Sometimes it is seen in younger people, and it presents with more fluid, more hemorrhage, both subretina, intraretina, and sometimes even breakthrough bleeding into the vitreous. So PCV could have quite devastating consequences if it's not picked up, and therefore it is a particular problem and a particular subtype of neovascular AMD that all clinicians should be aware of.
Very good. And it's my understanding that fortunately, when some earlier clinical trials were performed using Aflibercept at the initial dose that was approved by regulatory agencies around the world, 2 milligram Aflibercept, that it worked very well in cases of PCV. That is, it reduced the chance of the vision worsening, reduced the chance of breakthrough vitreous hemorrhages, and occasionally, or sometimes 30-40% of the time, led to improvement of vision. Is that what we knew with 2 milligrams?
I think with the introduction of Aflibercept 2 milligrams, there's been a really big change in our approach and management of PCV patients. In general, the visual acuity outcomes as well as the functional outcomes has improved with Aflibercept 2 milligram given to most, if not all, patients with PCV. And there has been a reduction in terms of the risk of serious retinal hemorrhages, risk of recurrence of PCV lesions, and in many patients that's treated on what is now commonly used, the treat and extend regimen. It has been shown to be able to have sustainable visual acuity gains 3-4 years after initial treatment.
Now, that's our standard treatments until we have this PULSAR study. The PULSAR study looked at a different dose of Aflibercept, 8 milligrams. And before we get into the subgroup of PCV within the PULSAR study, what was the PULSAR study doing with 8 milligrams in comparison to our standard dosage of 2 milligrams of Aflibercept?
The PULSAR study was a major randomized clinical trial that looked at randomizing patients with neovascular AMD to both the standard 2 milligrams Aflibercept versus the newer 8 milligram or high dose Aflibercept. And the way the trial was designed was that there are 3 groups of patients who are randomized to each of these 3 groups. And these groups are as follows. The standard 2 milligrams that was given every 8 weeks after 3 initial monthly loading doses. Then the 2 other groups were for 8 milligrams or high dose Aflibercept, and they were given every 16 weeks or 12 weeks after 3 monthly loading doses. So in essence, the PULSAR study was testing the hypothesis that the 8 milligram Aflibercept dose could be extended quickly for patients with neovascular AMD after the initial 3 monthly loading doses.
And as I understand it, fortunately, there was no sacrifice of visual acuity. It was not worse, let's say non-inferior. When you follow a protocol and do this every 12 or 16 weeks, as long as you rescued people if they needed to move back from that 12 or 16 week. Was that the bottom line of the entire PULSAR study?
Yes, that's correct. So in the PULSAR study, which has now results not only at 48 weeks, but also up to 96 weeks, basically the visual acuity gains with 8 milligram Aflibercept given according to the clinical trials protocol. In other words, every 16 or 12 weeks with even further extension after the initial 48 weeks, had reasonable and comparable visual acuity as to the standard 2 milligram Aflibercept dose. Of course, because they were given at 12 or 16 weeks or even longer, many of these patients in that trial could be extended safely without compromising visual acuity gains up to 96 weeks.
So was the PULSAR study designed to specifically look at the subgroup of study participants that had PCV, or did they merely collect that information and not necessarily choose that as a pre-specified secondary outcome?
So this was post-hoc analysis and was not the primary outcome, and therefore not all participants had PCV evaluated. So I would say this was an important subgroup analysis, but was not pre-specified at the beginning of the trial.
So for the randomization, people that had PCV were not necessarily randomized to one of those 3 groups. It was just a matter of, we'll look at this after this study is complete. And did you find that there were participants randomly assigned in fairly equal groups to 2 milligram or the extension to 12 or 16 week 8 milligram when they were found to have PCV?
The answer is yes. And we found that in this post-hoc analysis, the participants with PCV in all 3 of the groups were reasonably evenly distributed, and we did not see any major issues with biases from there, and therefore we could proceed with this pre-specified analysis with some level of confidence.
And how many people are we talking about within the whole PULSAR study? About how many actually were found to have PCV?
So in the PULSAR study, to diagnose PCV, some of the participants were eligible and had ICGA or indocyanine green angiography, which is the gold standard for diagnosing PCV. In the PULSAR study, ICGA was performed in 292 participants, and out of this, about slightly less than half, 139 participants had ICGA confirmed PCV. These 39 participants were reasonably evenly distributed in the 3 arms, the 2 milligram arms, and the 8 milligrams 12-week or the 8 milligrams 16-week arms. So we could look at the visual acuity and functional outcomes as well as the structural outcomes in all 3 arms with a reasonable level of confidence.
Okay, I see where we are now. We have this variant of neovascular AMD, this PCV. It may be more common in your Asian participants within PULSAR than the other participants. And we want to look at whether there's a outcome in that group, depending on whether you got the standard 2 milligram dose or whether you were randomly assigned to the 8 milligram dose every 12 weeks or up to every 16 weeks. So I know it's a post hoc analysis, but what did you find?
Well, we found that the visual acuity gains in all three groups were similar. And so the conclusion, which is the main outcome of this study, was that visual acuity gains at 48 weeks were similar between PCV patients that received the standard 2 milligram Aflibercept group versus the 8 milligrams given every 12 or 16 weeks after the 3 initial monthly loading dose. And the visual acuity gains were similar to patients without PCV, whether they were those that had ICGA to exclude PCV or in the overall PULSAR entire population. So it does suggest that PCV patients could be treated with Aflibercept either 2 milligrams or with 8 milligrams with very similar visual acuity gains up to 48 weeks.
So one concern of interest might be whether any of these groups, since it's PCV, had more frequent massive subretinal or sub-RPE hemorrhages or more frequent breakthrough vitreous hemorrhages. Did you see that with any of these groups, or was that a relatively uncommon event in all three groups?
In all three groups, these events were uncommon, and one of the major reasons is that these were in clinical trial settings. They were seen every 4 weeks, and every patient still received anti-VEGF suppression with Aflibercept. So I think the risk of some of these very serious breakthrough hemorrhages and massive retinal hemorrhages, it's uncommon when patients with PCV are given anti-VEGF to suppress activity.
And tell me a little bit about what we know using other agents other than Aflibercept 2 milligrams or Aflibercept 8 milligrams. Can we consider using ranibizumab for PCV? Can we consider using faricimab for PCV? I know that they're not compared in a head-to-head trial, but do the outcomes appear markedly different with those, or does it seem like anti-VEGF, if given appropriately, may be of benefit with many of these agents?
Yes, there's been quite good results in clinical trials and real-world experience with using other anti-VEGF agents, whether it's ranibizumab and more recently with faricimab. And the idea is that anti-VEGF agents such as ranibizumab, faricimab, or now Aflibercept, whether it's 2 milligrams or 8 milligrams, have generally good ability to maintain visual acuity gains if given consistently and if given with sufficient ability to monitor the patients over time. And I suggest that many clinicians now feel that PCV could be typically treated such as a neovascular AMD. And I think a lot of the protocols for neovascular AMD could be extended to PCV.
And finally, since this was a post hoc analysis, do we have to consider this just as hypothesis generating, or does it seem there's enough consistent information that you could consider these higher doses as used in PULSAR for patients that walk in with PCV?
I think the evidence is reasonably clear now. First, anti-VEGF suppression with Aflibercept, whether it's 2 milligrams or 8 milligrams, or even other anti-VEGF agents, will have beneficial effects for patients with PCV as they have been shown in patients with typical neovascular AMD. The second is that there is a possibility of extending dosing interval as was seen in the PULSAR study and other trials, whether it's given by protocol according to the clinical trial standards, or typically with clinicians we use a treat and extend approach. And I think the treat and extend approach applies to all anti-VEGF agents reasonably well, as long as the patients are maintained and are treated when they are needed to be treated. I think this suggests a major paradigm shift in two, I would say, settings. The first is that PCV patients should not be seen very different from typical neovascular AMD. Yes, they may be more common in some ethnic groups, like in Asian populations, but I think they can be treated like patients with typical neovascular AMD. The second and very important part that has changed practice over the last decade or so is the really reducing need to have patients that needs an additional therapy, photodynamic therapy. And photodynamic therapy is now given mostly for rescue treatment for patients that do not respond to the first-line anti-VEGF monotherapy regimens that we now typically use for patients with PCV.
And I know in another article published in JAMA Ophthalmology a few years ago, the results of the PLANET trial looking at Aflibercept, where a consideration of adding photodynamic therapy as a rescue could be done, was done so infrequently that it just may not be needed more than 5 or 10% of the time of cases that are followed carefully and treated appropriately with anti-VEGF agents alone. So this is just wonderful to hear. I'm so glad your group looked at this, shared it with us, and your explanation was so helpful and clear that this should really help clinicians around the world who are dealing with PCV. Despite perhaps the limitations of a post-hoc analysis, this is just wonderful for you to share with us. Professor Wong, thank you so much for doing this.
Thank you very much. It's always a pleasure to speak with you, Neil.
I'm Neil Bressler, Editor-in-Chief of JAMA Ophthalmology, and I've been speaking with Professor Tien Wong on a post-hoc analysis of a randomized clinical trial evaluating visual acuity outcomes using different Aflibercept doses for PCV, or Polypoidal Choroidal Vasculopathy. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi in the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thank you, everyone, for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.